This week on the BackTable podcast.
You know, I can see myself like complaining about a cholecystostomy tube and who like sometimes I think like the gallbladder is just like this culprit who like when no one knows what's going on, it's like all of a sudden someone's like, maybe it's the gallbladder. And then all of a sudden everyone hates the gallbladder and everyone's like, it's got to be the gallbladder. And people are clamoring for like the gallbladder's got to come out or we need a cholecystostomy tube.
Right.
And it's like a crowd that like a mob crowd that all of a sudden everyone's going wild against the gallbladder. And sometimes like I feel like I'm fighting an uphill battle to like, all right, well, let's just take a step back. There's a lot of reasons someone can have sepsis. The gallbladder is one of many. And so like I always like to take a beat and say like, you know, let's not put in this emergently. Let's do the workup, make sure it's appropriate, weigh the risk, weigh the benefits. But at the same time, there are patients that, I mean, it clearly makes a huge difference in, and, you know, if it's a source of sepsis, you know, you got to get the cholecystostomy tube done.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Our listeners asked, and we have answered. We now have CME available. You can get AMA Category 1 CME for listening to BackTable and then filling out a reflection. You can find the CME links on episode pages at BackTable.com, or you can also find the CME links in the show notes. It's a small cost for the credit, much less than you would spend at a conference, and it helps support the show. Powered by CMEify, using AI technology to bring the right education to the right place at the right time. You can do this in just a few minutes. If you're already listening to BackTable, might as well get a CME credit for it. Now, on with the episode. This is Aaron Fritts as your host this week. I'm very excited to introduce my good friend and our co-host, Chris Beck, to the show. Welcome, Chris.
Thank you for having me. Thank you, Aaron.
Sure. Another low-hanging fruit, bread and butter topic that you and I love to talk about. But I honestly, I think a lot of people get a lot out of these episodes. So let's jump right into it. We are going to talk about cholecystostomy tubes, how they're placed, why they're placed, where they come from, differences in technique. So first off, Chris, everybody I think knows who you are, but you know, just a quick intro about yourself.
Sure. I am Chris Beck, interventional radiologist, private practice, based out of New Orleans. Work a lot in Southern Louisiana, but primarily at New Orleans, and also BackTable host.
Great. And everybody probably knows I'm also an interventional radiologist in private practice here in Dallas, Texas. So first question is, where do these referrals usually come from for you, Chris?
Surgery, almost exclusively for surgeons.
Right. Usually it's because the surgeon doesn't, you know, the patient's high risk. They don't want to take them for cholecystectomy. Rarely, I mean, sometimes it might come from the ED via the surgeon via the ED doc, that sort of thing. But usually it's the surgeon who's making the call, hey, ask IR to put this in, right?
Yes. I mean, a lot of times, like in some super sick patients that are coming to the ICU, it's kind of a multidisciplinary approach. But I would say at some point there's been a surgeon encounter on someone I'm placing a chole tube on for our practice. I would venture to say 100% of the time.
That's true. Yeah. A lot of the ones that I would get in the middle of the night, a lot of times came from the ICU doc. But I think that's after they had a conversation with the surgeon that basically said the guy's too sick to go to surgery.
Are you placing these in the middle of the night?
I have. Yeah, I've had to.
Wow. Yeah.
Not anymore. As you know, I don't take call, but
Sure. But just a part of your practice, like that wasn't like an uncommon consult.
Right. Yeah.
Okay. I would say I've never been called in the middle of the night to place one.
It's always been like, oh, we'll do it first thing in the morning kind of thing.
One, I can just honestly say that like no one's ever called me like as the on-call doc to come in and place one in the middle of the night. I'm almost positive I never say 100% of the time. You know, if the patient's sick enough, I'll get out of bed, go see the patient, and depending on the situation, probably recommend that they could wait until the morning.
Yeah, got it. Yeah, I mean, I don't know. There's been I remember having that conversation with one ICU doc in particular who was like, look, this guy's really sick. You know, I don't remember if they were on pressors or anything, but they had some hypotensive episodes. They seemed to be, you know, in sepsis. So that's what pushed me to go in and put it in, kind of like a Neff tube, you know?
Sure. Yeah, and I can envision a world where like there's patients that would warrant that. I guess, you know, very possibly my acuity level, like in some of the hospitals I work at, is lower, or, you know, the ICU doc's tolerance for sepsis is maybe a little bit higher, but A lot of times we continue to cool them off with antibiotics and then place it like next available slide. Like I would say not emergently, but urgently.
Yeah. Either way, yeah, it's emergent or urgent for sure.
Yeah.
Do you usually have CT or ultrasound imaging ahead of time? And if you didn't, I mean, let's say they came from an outside hospital, what do you usually like need in terms of imaging?
Yeah, I would say that, they come to me at various levels of being like fully baked versus like completely not worked up at all. And the surgeon just kind of like eyeballed them and said, like, not a surgical candidate. I don't know if they got cholecystitis, but like, it doesn't matter to me because I wouldn't take out the gallbladder. And then it kind of gets put in my lap. I would say always I'll go see the patient and do an assessment, look at any prior imaging. I will go off ultrasound if like I think it's rip-roaring cholecystitis. If it's equivocal, may or may not get a HIDA scan. A CT, I'll only have if I have a CT because, they had one out of the ER or somebody ordered one, happy to like use CT, but ultrasound and HIDAs are what like I would be ordering.
Gotcha. Yeah, so one of those three typically, ultrasound, HIDA, and or CT, but a lot of times, like you said, it's usually just a HIDA and an ultrasound.
Yeah, definitely going to get an ultrasound. Like if for some reason they hadn't had an ultrasound, I would definitely get an ultrasound, even if they'd had a CT. Well, I don't want to say all, like, I mean, that's not 100%. Sometimes you can look at it and say, okay, that's cholecystitis. Yeah. But almost always I'll have an ultrasound and plus or minus on the HIDA.
Yeah.
HIDAs are kind of a mixed bag, right? I mean, a lot of false positives in HIDAs, but, sometimes it's helpful. Like if you happen to get a HIDA that shows a patent cystic duct, then you're kind of off the hook.
Yeah. Any labs you're making sure you got, like coags?
Yeah, definitely do coags, make sure that patients aren't on any anticoagulation. And not that that's a contraindication, but it helps me, it's a relative contraindication, certainly helps me stratify my risk and counsel either the patient or family members appropriately. So I'll have PT, INR, platelets, and I'm trying to think of what else. That's probably it. I can't think of it. Nothing else jumps out.
So just real quick, we're going to get to this in terms of our preferred technique, but if let's say there was an old person who's like septic, but they've been on Plavix, would that make you like decide, I probably won't go through the liver on this one. I'll probably go around it if possible when placing the tube?
Yes. So I don't feel strongly about going transhepatic one way or the other. Like all things being equal, I will go transhepatic. But if they were on dual antiplatelet therapy or just say Plavix, I would probably go just transperitoneal. And a lot of times the anatomy dictates it for me. I mean, like I just don't kill myself to make it transhepatic when, the anatomy's showing something different and vice versa.
Yeah, just kind of shortest pathway, safest pathway.
Shortest, safest pathway and, well below, like preferably, subcostal instead of intercostal. Yeah, and just like being cognizant of where you, like if you're, it's okay to go intercostal, just being cognizant of like how high you are and like your potential of transpleural transgression.
Right. Similar to putting in a biliary drain, just making sure that you're not, I mean, sometimes the liver's way up under the, especially if they have shallow breathing, and then you have them supine, the liver can be way up under the rib cage. And sometimes you have to go intercostal, but then count the ribs, make sure you're not going through the pleural space, right?
Right.
Well, cool. So, we kind of covered stick through the liver, not, I mean, I feel the same way. It just depends on the anatomy.
If they were on anticoagulation, like the anatomy is giving me either way and they're on anticoagulation, I would say that if the anatomy could go either way and they're on anticoagulation, and also depending on what anticoagulation it is, but like something I would considerably, I would say, dual antiplatelet therapy or, INR is like, 3, I would stay transperitoneal and avoid the liver.
Okay. Yeah, I mean, it's just for our audience to know what are the pros and cons of going to the liver or not going to the liver.
Well, how do you feel about it?
Well, so what I was told, sometimes something would look like a chip shot going around the liver, not through the liver, transperitoneal, is that can cause a biliary leak. And the reason for going to the liver is because you're going through an area where that gallbladder is facing the liver, so you're much less likely to have a biliary leak if you put that tube through the liver into the gallbladder. Does that make sense?
Yeah, absolutely. And that's what we were taught also. But I guess I've done a lot of cholecystostomy tubes and I've been transperitoneal a lot of times and haven't had a lot of, knock on wood, haven't had a lot of leaks. Also, I think it matters. So a lot of times the gallbladders are massively distended in these patients. And if you're like sticking the gallbladder when it's really, really distended and you're like having a really, really low stick, I think that also like matters. I try and anticipate like what the gallbladder would look like if it was decompressed.
Yeah.
Do you know what I mean?
Oh, that makes sense. Yeah, exactly. Yeah. So that when it gets decompressed, it's not like the tube's going to pull out
Right.
or be half sticking. You know, we've all seen those tube checks where the tube's like half pulled
Half
out.
filled out, yeah.
Right. And that might be, like you said, like once it's decompressed, it kind of sucks up under the liver and then your tube's sitting in a fixed place and it almost pulls out on its own. You know what I mean?
Mm-hmm.
So I could see that happening. But yeah, the going through the liver to me was just like to help prevent biliary leak, especially if you had like an issue getting the initial tube in, because that gallbladder can be kind of floppy, right?
Yes.
It can be all kind of rubbery and floppy. And if you don't if you don't pin it, then you might not be able to get that tube to pass through it. And so the liver actually, if you go through the liver, it kind of helps. It's that area where it's affixed to the liver and it helps almost pin it to get that tube to go in smoothly.
I totally agree. I think the gallbladder, and that's one of the reasons I like doing it under ultrasound rather than CT. It's a pretty dynamic organ. It's sticking. It's like sticking sometimes a decompressed bag, and I feel like there's a lot less play in the gallbladder as far as it like kind of just continuing to tint if you're transhepatic. Right. So totally agree on that.
Yeah. So let's talk about CT versus ultrasound / fluoro for these. I've seen people doing them both ways. What's your technique using imaging?
Ultrasound and fluoro always. And I say always with the caveat being sometimes you can't have it that way for whatever reason. Different hospitals you have different resources and available to you at different hospitals. So, I don't want to fault anyone who likes to do it under CT or, likes to do it with exclusively ultrasound, but I have my druthers, cholecystostomy tubes with combination of ultrasound and fluoro and in a cath lab setting.
Yeah, it's good to know both ways. I definitely prefer ultrasound fluoro because I like sticking it under real time under ultrasound and watching my wire coil within it under real time. Because like I said, when it gets all rubbery and tough and it's all inflamed, it can push away and you can end up even shearing the side of the gallbladder wall because it's not like sticking an abscess where it goes in and it usually will go in smoothly. It's all thick walled. And so what can happen is you can actually really mess up the gallbladder wall if you don't stick it dead on. And that's why I like to seal it in real time. That being said, CT is helpful at times when maybe you don't have ideal ultrasound access. Maybe like we said, the gallbladder's way up under the rib cage. You don't have great visualization with ultrasound. Maybe that the fluoro room's being taken up by a stat STEMI or something like that, and you have to do it under CT. One of the guys I know in my old group, he likes it under CT. He says, "Look, to me, it's just like sticking an abscess." And so that's why he does it under CT. He feels like it's faster that way.
I mean, if that radiologist or interventionalist, if it's faster and safer for them, then I wouldn't argue that. But for me, it's definitely faster, definitely safer with ultrasound and fluoro for a couple of different reasons. First, it's a dynamic area. Like if you just think about how much the liver will move with respirations, especially if you have like some of those ICU patients who are just like doing like big, deep belly breathing. I mean, like it's almost like your gallbladder can come in and out of focus, and like you're just waiting for it to like pop back into your window before you stick it. And it is like an abscess, but I think there are some differences. And one of the things that you mentioned was that a lot of times the gallbladder wall can be more friable, and as opposed to like a well-formed abscess wall, which they're not all like that, but it's almost like a half-baked abscess in that if you're not careful, if you don't have pretty good wire discipline and also like dilating, I think it is easy to push through. Or if you're not like pinning your wire very well, like with the dilators, or even when you're going on like with a stiff metallic or an inner stiffener that's metallic, I think you can push through the gallbladder wall. And I think we've actually talked about that before, where like I've done gallbladder cases where I'm dilating up and then I go to put the tube in, or like I'm adding a little bit more wire and it's just not tracking along the gallbladder lumen like I thought it was. And I've been out and like I've pushed through and through, or at some point like somehow lost access. And I think in the cases that I can remember, it was because like I was just not like very disciplined with the wire, and I think I continue to push through it with the dilator.
Yeah. Dilating is key because like we talked about, that wall is very rubbery. Mm-hmm. And if you don't dilate appropriately, you're not going to be able to get your 8 or 10 French tube in, and we'll get to size preference. But yeah, I think that adequate dilatation and also just speed and efficiency in which you're
Yeah.
doing. You're not dicking around waiting for somebody to load it on. It's like you got to have everything ready to go, because a lot of times it's super painful once you get that dilator in. And it, I do it with moderate sedation, but these guys can be like writhing in pain when you're dilating, right? Because it's so tender. And so that's why I think that you have to have everything ready to go to just boom, 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 dilate, get the tube in, and shoot and be done, But sorry, you were going to say something?
Well, I totally agree. And also, whenever you like having everything ready to go, I mean, that's like IR 101. And as you go through enough cath labs, you'll learn that you just can't trust every team that you're working with. But having like each dilator set ready to go, having the appropriately sized tube, because one of the things you really do not want to do is like, put the 10 French tube, the dilator in, take out the 10 French, and then you're like, all right, give me the tube. And a lot of times, like with my cath lab, they get mixed up. They always want to hand me like a biliary drain, which is like an internal external drain, because that's what it says. Right. And so that happens a lot. And so I'm like, give me the tube. And, as soon as I see it, I'm like, no, wrong tube. Give me the tube that looks like a nephrostomy tube. And so, honestly, that's not the situation where you just want to let the wire sit there and dangle in the patient. You want to go and keep the bile from leaking back either into the peritoneal cavity or along your tract. And so, put the dilator in, wait on them to get the correct tube.
Yeah, that's a good point. Yeah, because you're right. Bile could just be pouring out especially if you go the peritoneal route.
Yeah.
And that can cause an abscess, right? I mean, if it's infected bile, you could cause, an intraperitoneal abscess. So, all right, well, let's back up for a sec. When you're sticking under ultrasound, what do you prefer, UE or AccuStick?
I don't use either. I'll usually use
Chiba or something.
Well, I'll use it. I stick almost everything with a 20 gauge spinal needle.
Oh, interesting. Okay.
Yeah. What do you?
And you just do. I have done both. A lot of times when we're setting up, the tech will hand me like an AccuStick needle, and I'm like, give me a UE. I just want to, because I don't like the whole process. I don't think it's necessary. I think I can see the UE better under ultrasound. And to me, it's just like, in that sense, it's just like sticking an abscess. So whether I'm going through the liver or around the liver, I can see my needle clearly my UE needle clearly under ultrasound, get it right where I want it to. I can take a nice clean picture of it in the middle of that gallbladder lumen. And then I'm passing an 035 wire right away, right? I'm putting my amplats or whatever right away. And so that to me, it just saves steps. That way I don't have to do the micro wire and then, you know what I mean? And then the dilator. It's just an extra step of dilatation, I think.
No, I think that's very reasonable. What about, I mean, have you ever heard the argument that, you don't want to be sticking through solid organs, like either liver or kidney with like basically like a hollow needle, like the UE? Your UE doesn't have an interstylet, does it?
It doesn't, but I've never heard that.
Some people will say that. I don't think it makes any difference. Like I wouldn't have any problem going in with a UE. But that's why a lot of people won't do UEs for like nephrostomy tubes either. Like if you had a big dilated system, you probably wouldn't use a UE, or a lot of people wouldn't. Like you just go micro, like AccuStick.
That's true. That's true. But I've heard of people sticking big dilated collecting systems with 18 gauge needles just from the get go.
Yeah, I like using an 18 gauge needle also. I like that.
Yeah, but I've never. I mean, I guess you could do some damage because it kind of.
I think it's one of those things I think it's like one of those things like it's a risk that's kind of out there in the ether that someone brought up one time, but I don't think it comes up very often in practice. I'm sure someone out there, like if an audience member, please write us in and tell us when you stuck something like transhepatic and like you ended up with some kind of complication. I'd like to know.
Well, it's the inferior tip of the right hepatic lobe, so the vessels are going to be small down there anyway. So I don't know if I'd be worried about bleeding, or I guess that's all you would really worry about, right? It's
just a bleeding. Or pseudo aneurysm or something. And I also wouldn't worry about it.
Yeah.
But I use a 20 gauge needle only because I almost stick everything with a 20 gauge needle. I don't like the AccuStick sets. For ours, the needle's always 15 centimeters, which rarely I need. Way too long for a cholecystostomy tube. And so I like the 20 gauge needle. And I do like getting the AccuStick set. Like if I use the 20 gauge needle, it's few and far, but I will say if there's like kind of an equivocal patient and I am sticking and we should probably talk about this. Whenever you stick the gallbladder and inject contrast, are you just filling them enough to know that you're in the lumen of the gallbladder, or are you actually getting a cholangiogram? Like, if you have to see the cystic duct, or potentially not see the cystic duct.
Yeah, I mean, they're sick, so I'm just shooting enough to prove that I'm in the gallbladder.
Okay.
So two ways I'm confirming. One is that I'm, I'm injecting, or so I'm seeing visualization. I'm seeing that needle tip right in the middle of the lumen on my ultrasound image. And then as soon as I inject, I'm seeing contrast flowing. A lot of times it's kind of slow flowing within the bile, but you inject enough just to make out the form of the gallbladder, but not hyper injecting, because just like with a Neff tube or biliary tube, you can cause sepsis, right?
Right.
Or Rigers.
Rikers. Oh, yeah,
Well,
yeah.
they,
Yeah.
Yeah. Which I had that happen a couple weeks ago with a liver abscess. I remember you were talking about that, and it was a nasty liver abscess, but as soon as I drained it, they developed Rigers. So
Give them
they
Demerol?
developed some bacteremia pretty quick. Yeah.
You did give it Demerol? I always say, like, I've had it happen. I'll say, let's give some Demerol, and we never have Demerol anywhere close. So like, oh, we got to get it from the pharmacy. It'll only take an hour. I'm like, well.
I think that's what happened to us.
Yeah.
And I was just, and then like within 5 minutes, they went away.
Yeah, exactly. Yeah. By the time
yeah.
you're able to get the Demerol ready, they're already,
Right.
it's already resolved.
Right.
But it still is, it's kind of unnerving if you haven't seen it before.
Yeah. Yeah. Okay. So walk through the next step. So you have access, you injected, you're in.
Oh, hold on. I did want to say earlier on there are some times when people are asking me to do a cholecystostomy tube, and there's a lot of push, and it's smart doctors disagreeing about whether or not the patient has cholecystitis, right? I will sometimes get a little bit more aggressive with my contrast injection. And if I have a patent cystic duct, it's cholangiogram and I'm done. And that is very much the exception. 95+% of the time, if I'm injecting contrast, it's very much like you, that I'm just looking to see that I'm in gallbladder lumen, and I'm just using it just to then kind of guide where my wire goes and whatnot.
So when you inject, and if you see a patent cystic duct, then are you pull everything out and you're done?
Pull everything out.
Hey, they don't
done. Yeah, they don't have cholecystitis.
Yeah. Right.
I've kind of softened on that, because I know the pathophysiology should be that, like, you have an obstructed cystic duct, and if you have an obstructed cystic duct, that's like what leads to the blockage and the cholecystitis. But I wish that I was like a super smart guy and researched all the information on cholecystostomy tubes. But I feel like there can be like kind of this like chronic inflammation of the gallbladder with like poorly emptying like gallbladder ejection fractions in patients who are like ICU, like bedbound, like the acalculous cholecystitis, where you may actually have a patent cystic duct. I don't want to go too far on a limb and say that, and someone's like, oh, it's either patent cystic duct or nothing. I used to be kind of binary about it, but now I'm a little bit more flexible in that. I'm just less interested in seeing whether the cystic duct is patent. So I've kind of moved towards you, I guess. I
gotcha. All right. So you got your wire, you coiled your wire into the gallbladder, and then what's next? Then you dilate, and are you using an 8 or 10 French drain?
I don't use 8 for anything. I 8, like, usually if someone's trying to hand me an 8, I'll say 8 is for air, and then I'll say give me a 10 French. I don't put 8s in anything, unless a pneumo. That's why I say 8 is for air. It's almost always like a 10 French chole tube.
Okay.
Yeah.
I just put 8 French nephrostomy tubes in last week, just because the anatomy was like goofy, and I wanted to stay slow, low profile, and it wasn't like frank purulent urine. It was for diverting flow. So I was like, clear urine is going to be okay through an 8 French. You know what I mean?
Yes, I think that's totally fine. I just think the difference between an 8 French and a 10 French is pretty small. And for some reason, like in our practice, we place a lot of 16 French tubes for different things, suprapubics, abscesses, some chest tubes, not for pneumo, but for like complex effusions. Yeah. And I don't know, we place so many 16 French tubes that then I go and grab an 8 French tube. I'm just like, oh, it's still like nothing.
Seems like
nothing,
I'm like,
right. Yeah. And we even have 6 French tubes that some of my partners use for different things, and that just seems like absurdly small. But I think people do get away with it. Like there's a guy in town who does 6 French cholecystostomy tubes, and he trocars in, and that's fine. It just, to me, I just reserve 8 French for just anything like pneumothorax and whatever else you might be draining that has just air, and then 10 French and up for everything else, like nephrostomy tubes, chole tubes.
Yeah, 10 French is good because, if they're infected, then that bile's like thick and it looks like oil,
bile is
right?
Thick, yes.
So you got to have a 10 French, otherwise it's just going to get clogged. Real quick, before we talk about drainage, have you ever used a trocar for chole tubes?
I've never trocared in to a gallbladder, and I probably would not. And I very much do like to trocar into things.
Oh.
but I don't think I would do it for, no, I know I wouldn't do it for a cholecystostomy tube. Part of it's negativity bias. Like I remember very vividly in fellowship, we had a M&M for someone who was trying to trocar in. Actually, he was trying to trocar in under CT, which to me seems like a doubly bad idea.
Right.
But trying to trocar into the gallbladder, it kind of just did not go well, and the patient ended up dying. No, very, very sick patient, but it kind of stuck with me, and I would not do that.
Yeah, I just, to me, it's like ultrasound guidance. It's just so much safer to do it with Seldinger technique.
Yes.
I don't know why you wouldn't.
Yeah.
I mean,
I'm just not in that big of a hurry.
Why do you need to save 5 minutes to trocar? I mean, chole tube that goes smoothly takes literally 10 minutes.
Yeah.
If that. And so what am I saving time-wise to do a trocar, which, as you said, has only downside, which is complications?
Yeah, to be fair, there's probably a little bit of upside. Like I think the times that I've sheared, like I've pushed through the gallbladder, it's during the dilation process. And so like I think if you have a certain skill set, you got a really stable situation where like you're just lasered in on the gallbladder. Like I wouldn't fault someone for trocaring in. I like to trocar into things and also like whenever you're dilating, that's always like the biggest pain for the patients where you're dilating up. And so if you can just like save them that and just like get them very numb, like up to the liver capsule and then just go straight in. I get that. Like I think there's something to it, but I just think the risk outweigh the pros. Like you said, like it's Seldinger technique, tried and true.
Yeah, but I mean, that's the thing is like when you have that wire in, you can dilate over that wire. You have a track to dilate over, whereas trocaring in, you still got to shove that thing. It's a 10 French directly into the gallbladder, right?
Yeah.
So you got to have a backstop. And again, with the gallbladder being all floppy and stuff, I don't know. I just never could. Now granted, I've never tried it, and I know it was used primarily at bedside, right? For bedside placement. I've never had to do a bedside. You know, to me, it's just like we have the imaging guidance available. Let's do it the safest possible way. And so that's why I've never tried it. Now, I know people get trained that way, but now ultrasound imaging is a lot more accessible than it used to be. So
sure,
it might just be generational. I don't know.
Yeah, no, I mean, I totally agree with you, but I also can see where if you have some experience with it, you know that it works for you. Like, I wouldn't fault someone for saying, oh, I trocar in every time and like I don't have a problem with it. And I know if I, hit this part of the gallbladder or if it's like really distended. I'm betting people are not trying to trocar into like those gallbladders where it's like the ICU patients when they're kind of like it's the gallbladder walls thicken, but like it's not as distended as you would like. I run into those from time to time. I bet you people or different docs are probably not trocaring into that. That's my guess.
Okay. And then last thing I want to talk about is drainage bag or JP bulb. Which way do you go with cholecystostomy tubes?
To gravity every time. You do JP bulb?
Yeah. And I'll tell you why. Because that bile is super thick and infected, and I want to get it out. There needs to be some vacuum to pull all that infected fluid out. If it's just to a drainage bag, I feel like it's more likely to clog. The drain itself is more likely to get clogged. That's my take on it. Now, I don't have any science behind it, but...
Right. I would love to get the Twitter IR's opinion on this. I just assumed everyone was doing what I was doing. I never gave it a second thought. Like when you put that on the outline, like JP versus gravity, I was like, oh, is this a straw man? Everyone does gravity.
But what is the... Yeah, but like, that's the thing is Tex would always hand me the drainage bag. I'm like, no, give me a bulb. Because to me, it's just like any other infected space. I mean, other than like neph tubes, but there's a lot more pressure with the kidney pushing urine out through the tube. The gallbladder doesn't have that same kind of pressure, right? It's occluded. So you got to have something that's going to pull that fluid out. Otherwise, all that sediment and stuff the pigtail's sitting in is going to lead to it getting clogged. And that's my whole, now it's just, I don't have any science behind it, but I just feel like it's more likely to get clogged if you don't have pressure pulling it out.
I don't think my cholecystostomy tubes are getting clogged very often. I think like standard drain care, like, we still flush at BID or, I don't flush it, but nurses are flushing at BID.
You put orders in to flush at BID.
Oh yeah. Like I think I have like a
5 cc's.
I think it says 5 to 10 cc's. Like it's now like kind of an epic order set where like it's actually a dot phrase for nursing communication. But my thought was always that, you don't need to pull it out because the gallbladder is contracting. And so it's just going to go the path of least resistance. And if the cystic duct is clogged, then it's going to push it out into this big open tube. And also, like when I wouldn't have a problem doing a JP bulb, but when they go home, like say they fully recover, it's the ICU cholecystostomy case that fully recovers and is going home, but they're going home with a tube in. Are you still going to have it to a JP bulb?
Yeah, a JP bulb you can put in your pocket, whereas the bag is like, it's a whole, like where do you put the bag? It can't fit in their pants.
Mm-hmm.
It's got to sit on the exterior. So I feel like the patient appreciates the JP bulb more as well.
That might be true. I always thought that, or my line of thinking was that, at some point, it's very possible that the cystic duct opens up or whatever they had going on in the ICU has kind of relaxed. And some, sometimes you do chole checks. I mean, that's the whole point of doing the chole check is like you put the dye in, then all of a sudden you have a patent cystic duct. And so having like a gravity bag allows that bile to have like a choice, like, hey, I can still go into the bag, but if the cystic duct is open, like I'm gonna flow the anatomical route. And in fact, in med school, like this kind of stuck with me, but I didn't do it in residency or fellowship. The IR doc would have the patients wear their gravity bag high, like on their shoulder, and the idea was that like the path of least resistance, he wanted to push it more towards the cystic duct.
Oh, okay. Huh. That's interesting. Yeah, because then that way pressure's building up to clear it out.
Yeah.
Yeah. Well, I don't know. Maybe there's a paper out there about this. I've yet to see it, but if anybody in the audience knows of any science behind this, like it's like a myth buster, maybe we can solve it.
I suspect it's one of these things that all roads kind of lead to the same place. That my cholecystostomy tube checks aren't having like any higher degrees of patency with the cystic duct than yours are.
Yeah.
I think like if I had to guess, my gut says that either one will work well.
Yeah.
Yeah.
Well, on a scale 1 to 10, where do cholecystostomy tubes sit on your least favorite to favorite procedures?
I'm pretty neutral towards cholecystostomy tubes. Like I'm not for them or against them. Like I would say 5 because like sometimes, I can see myself like complaining about a cholecystostomy tube and who like sometimes I think like the gallbladder is just like this culprit who like when no one knows what's going on, it's like all of a sudden someone's like, maybe it's the gallbladder. And then all of a sudden everyone hates the gallbladder and everyone's like, it's got to be the gallbladder. And people are clamoring for like the gallbladder's got to come out or we need a cholecystostomy tube.
Right.
And it's like a crowd that like a mob crowd that all of a sudden everyone's going wild against the gallbladder. And sometimes like I feel like I'm fighting an uphill battle to like, all right, well, let's just take a step back. There's a lot of reasons someone can have sepsis. The gallbladder is one of many. And so like I always like to take a beat and say like, let's not put in this emergently. Let's do the workup, make sure it's appropriate, weigh the risk, weigh the benefits. But at the same time, there are patients that, I mean, it clearly makes a huge difference in, and if it's a source of sepsis, you got to get the cholecystostomy tube done.
Yeah, for me, there's somewhere around a 5 or 6, I think. Mostly
6 would imply that you're for it in some way, like you're like, oh, a cholecystostomy tube's on the schedule, that's going to be good.
Well, it's just that like I find them kind of satisfying because the patients do get better, and like there was a surgeon who was like, hey man, you helped save this person's life. They were really sick and I couldn't take the gallbladder out. And so in that sense, it's very satisfying. They tend to be like always at the end of the day. It's always like 3 p.m. consult, like, hey, we really want to get this, chole tube in before tomorrow. And you're like, okay, we'll just tack it on at the end. So I always feel like they're like late afternoon cases. And that's why I'm not like a 7 or an 8.
Okay. I can sympathize with that. I would say one, if the surgeon ever told me, hey, you made a big difference and like, we saved this guy, I would say, duh. I would say, duh, just like all my other procedures. And I guess the other thing is, a lot of times I'm not in a hurry to, if a patient truly is septic and needs it emergently, I will certainly spring into action emergently. Like if someone consults me at 3 p.m. and they're like, hey, we'd really like to get this done. Like I always offer it. I always offer to see the patient, or like I make it my point to see the patient before I'm done with the day. But their acuity level, just because they're in the ICU, does not mean like I feel like it's an emergency to get it done. And I'm not going to stress our resources just because they kind of like treaded water from like a large part of the day, then to consult me at 3 o'clock.
Right.
Yeah. But I do think that, it's like it behooves like other interventionalists, like have a clinical practice, be able to see the patient, weigh in. If you're just mad about the 3 p.m. consult and you're going to kind of like, kick rocks around, then you just got to go see the patient, decide whether it's appropriate or not. And I think like you'll get a lot more job satisfaction in knowing that the person that you're doing at 5 p.m. is because they're sick and they deserve a cholecystostomy tube, not because like someone consulted you late.
Right.
Yeah.
Cool. All right. Well, I think that was a pretty good discussion of cholecystostomy tubes. Chris, anything we left out?
I wanted to talk real quick about antibiotics, like what you do for antibiotics.
Oh, yeah. Well, usually by the time they already have them hanging. Usually so I'm not giving antibiotics.
Okay. How about this? So, I mean, they're almost always on antibiotics. I mean, it's the exception rather than the rule that they're not. But what if they've had antibiotics, like you're doing the case at noon and they had antibiotics at like 6 a.m.? Do you still try and give a dose right before you, like within an hour of stick time?
No, because they're already on some sort of antibiotic regimen. At that point, they're admitted or they've gone to the ER and they've made a decision. This patient's septic or they're sick. They have cholecystitis and somebody's already started them on antibiotics. So I've literally, not, unlike maybe a Neph tube or something like that, I've never said, hey, hang the antibiotics, because usually they're already ordered or hanging already.
That's fair. I will usually try and time my procedures where, like, if they have like a dose that's coming up, I'll hold that dose to where we give it within an hour of like me sticking the gallbladder. And if they don't, I might actually give them a boost of like whatever like appropriate antibiotic, maybe it's one that they're on, or maybe it's just like a gram of Rocephin, like within an hour of my stick.
Okay.
Yeah. I'm curious about what other people do.
Yeah, so when we put this one out, I am going to pull the Twitterverse on a couple of these things. This will be fun because it'll be kind of easy, like UE versus Agu stick, through the liver or not. We could do CT versus ultrasound. We could do drainage bag versus JP bulb. There's a number of different polls we can throw out on social media.
Sure.
And then around the time of this release. So I'm looking forward to the feedback.
Yeah. Oh, you also mentioned bedside cholecystostomy tubes. You haven't done any bedside?
I have not. I guess if there was some extreme case where the lab was shut down, CT was shut down, apocalyptic, situation where there needed to be a bedside, then I would do it. But I think ultrasound / fluoro is essential, and my secondly, I would do CT if necessary. But nobody's ever asked me to do a bedside. I don't know why I would.
We've been asked, like a lot of times we get pushed back when we're like, hey, we got to take them to cath lab, and they're like, can't you just do it bedside? And I don't even. I would if I thought the patient was truly unstable and like a transfer would potentially kill them. But so I have done a couple of bedsides, but 99% of the time I'm going to push for them also to be in the lab. Only because I think it's if it's appropriate. I think you sometimes can have a very like routine procedure, but if you like strip away all your resources and put yourself in like your non-comfort zone. If bedside is your comfort zone, then go for it. More power to you. But that's certainly not mine, and certainly not where all our resources are available to us. And so I'm very much I want to do it where I just tell the referring docs. It's usually pulmonologists or intensivists that. I'm like, this is a procedure. It's almost like a surgery, and you're not going to ask a surgeon to operate in here. Sometimes they'll push back.
Right.
And sometimes like the surgeons do operate in the ICU settings and tertiary referral centers. But I'm like, no, I just need all my equipment, my team, like the patient. Everyone who knows like how to put in a cholecystostomy tube. It's not just me. It's a team approach.
Right. I think that's fair. I guess if they're like super sick and they can't, like you said, they can't travel to the lab or to CT, and they're pushing hard. But that's yet happened to me. Knock on wood. Hope it never does. All right. Well, sounds good. Well, thank you for listening to the BackTable podcast.
All right. Thanks, Aaron.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck,
Sabine Dond,
Michael Barraza,
Brian Hartley.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson.
And Ness Smith-Savadoff.
Design and Digital Marketing led by Brian Schmitz, with support from
Zubi Syed,
Article and transcript support by Taylor Robinson,
and Delaney Aguilar.
Social media and PR by Ann Dang,
and newsletter by Lauren Fang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.